So Laura Bamford is board certified infectious disease specialist who specializes in, excuse me, treating people living with HIV and at high risk of contracting HIV. Patients may also have opioid use disorder or hepatitis C. And as I think almost everyone knows, Dr. Bamford is the medical director of our wonderful Owen Clinic. Prior to joining UC San Diego Health in 2020, she was the medical director of Clinica Bienestar, an HIV clinic in Philadelphia with Spanish-speaking physicians and staff. Dr. Bamford completed fellowship training in infectious diseases at the Hospital of University of Pennsylvania. She completed residency training in internal medicine at Columbia University Medical Center and earned her medical degree from Jefferson Medical College. Outside of work, she enjoys listening to music, biking, running, skiing, and traveling. Also rooting for the Eagles because as a Giants fan, it's personal. and then Laura, do you want to give us any other fun or interesting fact before you dive into your presentation?
Yeah, so tonight, for those of you who don't know, I have a 17-year-old son who is goalie on the Point Loma High School soccer team. And tonight's senior night, so I get to go and walk out on the field with him. So I'm very excited. He's very nervous. And I was like, oh, that's nothing. I have to give high rounds this morning.
Oh, well, that's great. Okay, well, we'll turn it over to you, Laura. I'll keep an eye on the chat and stop you if it seems appropriate. Otherwise, we'll save it for the end.
Perfect. Thank you so much, Jill. All right, so I have no financial disclosures, and so I'll jump right in. So I know most of you know, but for those of you that don't, the Owen Clinic was founded in 1982, and our anniversary is actually coming up this June. It'll be 40 years since Dr. Chris Matthews had the amazing vision of starting the Owen Clinic, and we've grown to become the largest, most comprehensive HIV primary care center in San Diego. And our mission is to provide compassionate, culturally competent, and patient-centered care for people living with HIV, but also at high risk of HIV acquisition. And in 2020, we were recognized by the Human Rights Campaign Foundation as a leader in LGBTQ healthcare equity. And every year, our amazing medical providers, nurses, pharmacists, social workers, care navigators, care for, counsel, educate, and support about 3,200 people living with HIV and about 300 more people who are at high risk of acquiring HIV. So this is our amazing HIV primary care team. I'm going to talk about a lot of these amazing people during the talk today, because everyone really is an integral part of the support and care of our patients. Here's our incredible specialty care team, really comprehensive. This is representative of the comprehensive care that we deliver. And here are all of our services, all the things that we're doing, and then things that we hope to do. We hope to start Medicare annual wellness exams in the near future. Under the leadership of Miley Karras, over half of our patients are over the age of 50. So really important to, focus on HIV and aging. And then we also hope to move the adolescent HIV medicine clinic here to the Owen Clinic under the leadership of Jill Blumenthal, Gigi Blanchard, and Lisa Stengel. And that we think will really help with that sometimes difficult transition between adolescent care and adult care. All right, so we're going to talk about, I know all of you have seen this many, many times, but we're going to talk about ending the HIV epidemic today, and how does the Owen Clinic fit into this plan, and really focus on the 4 science-based strategies, and actually maybe 3 of these I think that the Owen Clinic can really help with, which are the diagnose, treat, and prevent pillars, with the goal of reaching a 75% reduction in new HIV infections by 2025 and at least 90% reduction by 2030. And this also similarly focused on the HIV National Strategic Plan, which has 4 goals. Goal 1, to prevent new HIV infections. Goal 2, to improve HIV-related health outcomes of people living with HIV. The third goal is to reduce HIV-related health disparities and inequities. And finally, goal 4, achieve integrated and coordinated efforts that address the HIV epidemic among all partners and stakeholders. So before we jump into what the Owen Clinic can do to support these efforts, I want to present a little bit of the epidemiology and what the focus of this plan for America is. Because if we know the population that's most at risk and most vulnerable, we'll be able to design the best possible intervention. So this is the first phase of the ending the HIV epidemic, and it's really focused on 48 counties plus Washington, D.C. and San Juan, Puerto Rico, where greater than 50% of HIV diagnoses occurred in 2016 and 2017. So San Diego County is one of these 48 counties. And then there's an additional 7 states, mostly in the rural South, that has a substantial number of new HIV diagnoses. So here is a graph of HIV incidence in the US. So HIV incidence peaked in 1984 with 130,000, over 130,000 infections, and has declined significantly through 2015, and then kind of stagnated for a few years. But between like 2016 and 2019, we've seen about an 8% decline in incidence each year. But you can see that we're still far away from the targets in 2030 of 3,000 infections each year. And this is a cool model that I found that is called the social ecological model of HIV risk and vulnerability. So really, like, where can we focus our efforts to decrease new infections and support people living, and also support people living with HIV? And I think really where the Owen Clinic can be most focused is on level 1, and so focused on the individual factors of our patients. So what are some correlates of viremia, or promotion of viral suppression? So focus on the syndemics of mental health and substance use, supporting our patients with unstable housing, supporting those involved in the criminal justice system, improving self or internalized stigma related to HIV, poverty, and supporting our younger folks living with HIV. And then correlates of acquisition are quite similar. So increasing status awareness, but also supporting folks, again, with mental health concerns, substance use, promoting more condom use, treatment, testing and treatment of STIs, and promoting more PrEP adherence. Okay, so now back to the epidemiology again. So we understand the populations most at risk and where we really need to focus our efforts and help us design the best possible intervention. So more than 1.2 million Americans are currently living with HIV in the US, about 13% unaware of their status. We've lost more than 700,000 Americans since 1981 to HIV. And Black people, who represent only 13% of the US population, have accounted for 41% of those deaths. And HIV continues to have a disproportionate impact on many populations, particularly Blacks and Hispanics or Latinx persons, people who use drugs, people who live in the South, particularly in the rural South, transgender and gender non-binary persons, and gay, bisexual, and other men who have sex with men. And even outside of the current COVID pandemic, there are still many unresolved health inequities that threaten the progress of the Ending the HIV Epidemic initiative, and even threaten to reverse the amazing declines in HIV incidence that we've seen since the 1980s. So this is a map. This is data from AIDSview, which is our data that are obtained from the CDC National HIV Surveillance Program. So this shows the prevalence of in the US by county of HIV, and the rates are per 100,000 people. So you can see there, here we are in San Diego with rates about 470 per 100,000. And how this compares to the rest of the US is, we have far higher rates of prevalence compared to the state of California as a whole, compared to the Western US, and compared to the United States overall. And then for incidence or new diagnoses, our rates are about 13 for 100,000 people, and how that compares to the rest of the US. We're about similar to the region, state, and in the United States. Now, as I said earlier, HIV does disproportionately impact certain populations. And for Black and Hispanic people, this is prevalence. You can see that Blacks make up about 12% of the US population, but 40% of all prevalent HIV. And for Hispanics, it's about 19% of the US population, but 25% of all prevalent HIV. And for Black female adults and adolescents, who represent 13% of the female population, they're particularly burdened with 55% of all new diagnoses in 2019 amongst women. And the same goes for new diagnoses. So in 2019, Black individuals accounted for 41.7% of all new diagnoses, but only 12.5% of the US population. And Hispanic or Latinx individuals accounted for 28.6% of new diagnoses, but only 18.5% of the US population. And these are our numbers here in San Diego. So there's our population, about 3.1 million in 2019, and the breakdown of our population by race, ethnicity. But just like the national numbers, so this is in the red are people living with HIV in San Diego. So Blacks make up 4.7% of the population, but 11.9% of all prevalent HIV. And Hispanic or Latinx individuals, 32% of the population, but 39.3% of people living with HIV. And then for diagnosis, you can see, and what this really shows is that over time, so African American individuals still represent 12% of new diagnoses, but you can see among Hispanic and Latinx individuals over time are making up a larger percentage of diagnoses, and then ultimately probably a larger percentage of people living with HIV. So as HIV incidence is declining in amongst other populations, it's still declining amongst the Hispanic and Latinx individuals, but they're making up a larger percentage of those living with HIV over time. So, I think what this clearly represents is that access to prevention and treatment and messaging are not reaching certain populations equally. And this is overall prevalence in the US by transmission category. So you can see in 2019, and this is, again, prevalent HIV, those living with HIV, by far, the largest number of men living with HIV reported male-to-male sexual contact as their transmission risk factor. And that same year of new diagnosis, you can see that now men who have sex with men represent 81%. So again, over time, a larger percentage of diagnoses are among men who have sex with men relative to men who report injection drug use or heterosexual contact as their transmission risk factor. So again, over time, greater burden of diagnoses among men who have sex with men. And this is further exemplified by this graph, which is diagnoses of MSM by race and ethnicity. So you can see the top line is all men who have sex with men with really stable diagnoses over time. And also amongst Blacks, you can see that amongst whites, new diagnoses have declined over time, but new diagnoses among Hispanic or Latinx men are actually increasing, which is really what's driving that increase in overall overall larger percentage of new infections in Hispanic and Latinx individuals. And this is just a reminder that even though overall the percentage of new diagnoses amongst people who inject drugs has declined, there's still, over the last several years have been several outbreaks amongst people who inject drugs across the country. And because we're still in the midst of a methamphetamine and opioid crisis, we just have to be aware that we may see more of these outbreaks if we don't help support, further support this patient population. All right, and so a little bit about health insurance coverage, which really speaks to access to all that we're going to talk about later, to all the prevention and treatment interventions. So these are two data sources, so we can't do any statistical analysis to determine statistically significant difference. But what this does show is that adults living with HIV are more likely to have, and not statistically more likely, but more likely to have Medicaid insurance compared to folks not living with HIV. And these are from the same data source, because these are all folks living with HIV. But amongst women living with HIV, they're significantly more likely than men to have Medicaid insurance. And then amongst race and ethnicity, Black individuals are significantly more likely to have Medicaid insurance compared to white individuals. And both Black and Hispanic individuals are far more likely to be uninsured compared to white individuals. And this is particularly significant in states that haven't expanded Medicaid, because when that happens, you see a far larger percentage of people who are uninsured. And whereas California has expanded Medicaid, anyone who works at the Owen Clinic knows that we still don't accept all Medicaids here. So really does limit access if you have Medicaid, to the Owen Clinic and other services at UCSD. So I like to say that UCSD really needs to expand Medicaid also. All right, and this is these are the health and human service area regions for San Diego County, and this is based on our Ryan White funding and which counties the Owen Clinic serves. So we are here in the Central County. So what you can see from this, and these are new diagnoses in San Diego County, so amongst San Diego County residents. And I should point out these are residents, so none of this data captures patients who may live in Tijuana and cross the border. This is just San Diego County residents who were diagnosed between 2016 and 2020. And you can see that here in the central region where the Owen Clinic is located, we're really in the epicenter of the HIV epidemic here in San Diego, both for diagnoses and for prevalent HIV. And here are the HIV Care Continuums for the United States compared to San Diego County. So a few things that stand out are many people, up to 20% nationally and 18.7% locally in San Diego, are coming into care or getting diagnosed late. So meaning they have simultaneous AIDS diagnosis with an HIV diagnosis. But we're doing slightly better here in San Diego of linking people to care and equal to the United States in receipt of care and slightly lower viral suppression rates here in San Diego. And then particularly amongst Blacks in San Diego, they are significantly less likely to be retained in care and virally suppressed compared to the overall population of people with HIV in San Diego. And similarly, individuals who report injection drug use as their transmission risk factor are also significantly less likely to be virally suppressed here in San Diego compared to the overall population of people with HIV. And this is a cool graph that I found. So this is called PrEP to need ratio. And so this is really an epidemiological proxy for PrEP need in San Diego County. And what this ratio is the ratio of the number of PrEP users, or people who prescribe PrEP in 2019 over the people who were newly diagnosed with HIV the previous year in 2018. So it's really a measurement of whether PrEP use appropriately reflects the need for HIV prevention. So a lower PNR indicates more unmet need. So we're doing pretty well. You know, the overall national PNR is 6. Our overall in San Diego is 7.3, and you can see is increased dramatically over time. But what you can see is we're not doing so well amongst women in reaching them with PrEP, those who need it, and also in younger individuals, and then in folks over age 55, we're not doing as well as reaching them. Okay, so now on to what can the Owen Clinic do? In light of all this epidemiological data, what can we do to help end the HIV epidemic in San Diego? And I really like this model, the things that maybe we can focus on, because I think all of the things that you see on this wheel really impact not only engagement in treatment, but also prevention. So the rest of the talk will focus a little bit on the efforts that the Owen Clinic is doing to support our mental health concerns of our patients, substance use, these other things that are syndemic with HIV, poor access to healthcare, HIV-related stigma. I wish we could do more, related to housing here at Owen, but that really, has to be more of a county and statewide effort, and supporting our folks coming out of the criminal justice system. And then finally, low health literacy, which I think is kind of an unfortunate term and maybe not as patient-centered as it could be. And really, is focused more on what can we do as providers to make sure that our patients are well informed, and perhaps even really starts in like middle school and health class. And as you can imagine that some of the places in the US that are struggling the most with new infections, like the rural South, are probably places where in health class, the sex ed is not, sex positive. They probably don't discuss sexual orientation. They probably don't discuss gender identity. So we can be doing far more. Okay, so one of the first interventions at the Owen Clinic. So this is a graph, and this is thanks to Afsana Karim, our data analyst. Just applauding our amazing pharmacists who do all of the intake appointments at Owen. So they see all of our new patients, people either newly diagnosed or coming back into care. And what this shows is that we've been able to get those patients into their first appointment within 7 days. That's our goal. And in some months, within 3 days on average. And that really allows us to rapidly start and rapidly restart patients on ART. And as part of that intake visit, new patients will meet with our pharmacists, they'll meet with our patient navigators, our financial counselors, and our social workers. And what that does, it really avoids patients needing to come in for multiple visits to address potential barriers to care, and it allows for the rapid simultaneous establishment of rapport with multiple staff members. And our care navigators are assessing for potential barriers to care. Now they're using this new acuity scale that they administer at that first visit, and it really looks at all of a whole bunch of domains of potential barriers to care. So things like substance use and housing, and access to health insurance, and they give patients a score, and based on how high that score is, then they determine kind of what is the next step. And for patients who have very high acuity needs, they'll get referred out to case management. And for those kind of in the middle, our care navigators will follow them at least for 6 months until they're established here. And then our clinical pharmacists, they order any necessary laboratory studies that first day. They complete a thorough HIV diagnosis and treatment history. They review ART and HIV resistance testing history, and they prescribe ART or get people back ART. And then all of these new patients are hopefully scheduled with their new primary HIV care provider, ideally within 2 weeks of that visit. All right. Now on to the concept of U equals U. And this concept is really can be used in a lot of ways. And these are several studies that have showed that it can improve engagement in care, reduce stigma. And the first one was called the Positive Perspective Survey. And this showed benefit of healthcare providers discussing U equals U with their patients. And this was based on data from 25 countries. This is the 2019 Positive Perspective Survey of people living with HIV on ART. And they found that overall, 2/3 reported ever discussing U equals U with their healthcare provider. But compared to those that were unaware of this concept, those that reported U equals U discussions with their healthcare provider had a lower odds of suboptimal adherence and higher odds of self-reported viral suppression. And while exposure to this information from non-healthcare providers was beneficial, the observed observations, the most benefit came when these discussions happened with their healthcare provider. And then another study from South Africa that looked at U equals U messaging to increase uptake of HIV testing there. So this study compared HIV testing during standard of care, which was just the standard of care was just that a peer promoter would inform men that there was a mobile clinic where they could get tested on certain days. And then the study intervention was peer promoters delivered the U equal U messages. And when the peer promoters followed standard of care, so without the U equals U messages, they delivered 1,048 invitations over 12 days. And in the standard of care group, 68 of 544 men invited actually were tested, and they with 3 positive men discovered. But in the U equals U group, 112 of 504 men invited or actually tested. And they discovered 7 positives. So the men in the U equals U group had greater odds of getting tested compared to the standard of care group. And the thought was that when you're messaging that untransmittable, undetectably goes untransmittable, that there's far less stigma related to getting tested in the first place. And then finally, another study that showed that U equals U messaging reduces the burden of stigma for men living with HIV. And this was an online survey amongst 30,000 adolescent and adult sexual minority men living with HIV across the US. And it found that 80% of those surveyed reported that U equals U was beneficial for their self-image and societal HIV stigma, and 58% reported it made them feel much better about their own HIV status, and 40% reported that it had potential to make HIV stigma much better. So over the last year at the Owen Clinic, we've developed a smart phrase that goes right into all of our progress notes in our electronic health record, which is EPIC. It includes a whole bunch of we have other like Ryan White metrics. It's part of our Ryan White funding. But at the bottom, you see that we've incorporated the U equals U messaging so that every visit with our patients, in addition to doing a tobacco assessment and substance use disorder screening, we're also making sure that our patients are aware of this very important messaging. All right, so on to some work that we've been doing here at Owen to support our patients with mental health concerns, because mental health not only increases someone's risk of HIV acquisition, but also impacts ability of people to engage in HIV care. So this is a model that we've recently incorporated called the Behavioral Health Consultant Model, and BHCs are generally PsyD, PhD, or master level clinicians who typically see an individual patient for a limited time and a limited number of visits. And BHCs are integrated into primary care clinics. They get warm handoffs from PCPs with immediate feedback to the provider. And these visits are typically brief, like 10 to 30 minutes. They're solution focused, and they aim to provide patients with tangible behavioral skills to improve their overall daily functioning and optimize health. And BHCs really balance the time that they work with patients with the need to make these services available to a sizable clinic population like the Owen Clinic. We have 3 BHC positions and 3,200 patients. But BHCs have the capacity to treat many behavioral health concerns, including depression, anxiety, substance use, insomnia, smoking cessation, and then other situational stressors. So when patients present with relationship conflict or grief at the loss of a friend or family member. And BHCs can also support patients improve medication adherence, better manage chronic diseases, and encourage safer engagement in high-risk behaviors. And when behavioral, these models have been incorporated into primary care clinics, they've been shown to significantly improve mental health and clinical outcomes amongst participants. And a large family medicine clinic in Texas demonstrated significant improvement in global mental health functioning after patients engaged in these brief behavioral health interventions. And this improvement was sustained even 2 years after these brief interventions, which are really sometimes only like 2 to 4 visits with the BHC. And when these models have been incorporated into HIV primary care, so this was an intervention in Philadelphia where they incorporated BHCs into 6 clinics there, and these were 469 participants who had somewhere between 2 and 5 sessions with the BHC. And you can see prior to the intervention compared to after, they had significantly higher retention in care, ART prescription, and viral suppression after these brief interventions. All right, now shifting gears to how can we support our patients better with substance use disorders, and particularly methamphetamine use, which is by and large the largest substance use disorder we see at the Owen Clinic. So what is the impact of methamphetamine use on HIV treatment and prevention? So persistent use of methamphetamine was found to be the biggest predictor of HIV seroconversion in this online study amongst men who have sex with men. This is an ongoing nationwide internet-based cohort, which found that men who have sex with men who have persistent methamphetamine use had 7 times the odds of HIV acquisition compared to men who did not use methamphetamine. And in this study, the rates of persistent use were highest here in the West with 12%. And amongst men who have sex with men living with HIV, they're more likely to have condomless sex with partners without HIV or of unknown serostatus, and are less likely to be virally suppressed. And in a clinic-based study in San Francisco, it showed like how prevalent methamphetamine use is in our patient population. So 20% of MSM, 16% of heterosexual men, and 15% of women reported methamphetamine use in the previous year. And then a recent cross-sectional study that analyzed data from a large cohort of patients found that participants who reported using methamphetamine disclosed higher risk use over time. So meaning that folks who had started out maybe smoking or using methamphetamine intranasally over time were going on to inject it. And the study also demonstrated that methamphetamine use during this 4-year period diversified to populations who had not previously known for prevalent use. So historically, methamphetamine use has been most common amongst white middle-aged men, but in this study, while methamphetamine use more than doubled among MSM during this time period, it also more than doubled amongst heterosexual men and more than tripled among women. And the study also showed that methamphetamine use increased 300% in young individuals and tenfold amongst Black persons. So one study that we're enrolling here at the Owen Clinic to help support our patients with methamphetamine use disorder. And this study is supported by the San Diego CFAR through a CFAR supplement. And collaborating with this study on Amu Rajgopal, Dave Grilati, and Jessica Montoya, and Vernay Justice Royster. So, as part of this, first of all, given that recent data from that large cohort study nationally, we really want to identify, who is our population of individuals who are using methamphetamine, so we can best design interventions to support them. And we're going to use ICD-10 codes and urine drug screens to, first of all, just define what is the prevalence of methamphetamine use in our population. And then, further define this population by age, gender, race, health insurance status, HIV transmission risk factor, last HIV viral load and CD4 count, Hep C antibody positivity, as a marker of shared injection equipment, and then retention in care, STI diagnoses as a marker of riskier sexual behavior, and really, again, to really define who this population is and learn how to best support them. And then part of this study will also be incorporating therapies for methamphetamine use, like really integrating them into the Owen Clinic. And these are two behavioral therapies called contingency management and cognitive behavioral therapy that Jessica Montoya presented on at a previous high rounds. And these are really really the only approved and recognized treatments that have been effective to reduce methamphetamine use. There are several pharmacologic therapies, none of which are FDA approved, that will also be looking at uptake of those and kind of use in our population. But this study will really be behavioral therapy study, and we really want to know, what is the feasibility and acceptability of integrating these therapies into HIV primary care. And we'll be surveying folks, and also be surveying folks on their satisfaction with the program. All right, now on to a little bit more epidemiologic data. And this is a study in 7 cities across the US amongst transgender women, and 1,608 transgender women participated in this study. And it was really designed to try to get a sense of what are the rates of HIV prevalence amongst transgender women. We really don't have great data on this in the United States, but in this study, 62% of Black or African American transgender women reported living with HIV. 35% of Hispanic and Latino women reported living with HIV, and 17% of white transgender women reported living with HIV. So at the Owen Clinic, with the incredible, under the incredible leadership of Jill Blumenthal, we are going to be expanding the gender affirming care that we provide. And Jill has worked tirelessly to create a comprehensive gender health program here at UCSD. We're planning to hire medical and surgical clinical care coordinators to support this. And in addition, to providing transgender and non-binary folks with with gender health and gender affirming care, we're really hoping that this will also meet some of the unmet needs that delay or interrupt HIV treatment, as multiple studies have shown that transgender individuals really prioritize the gender affirming care over HIV treatment and prevention. And if we can combine both at the Owen Clinic, then hopefully we'll increase engagement and care for both. When gender affirming hormone use was not incorporated into HIV primary care, there was a lower odds of not being on ART. And there is a large study about to start through the HBTN in 5 sites in 5 cities across the country, and I think also in Rio de Janeiro. And this study is going to assess whether providing gender affirming hormone therapy at the same clinic as PrEP will improve PrEP uptake and reduce HIV acquisition, just what we're already doing at the Owen Clinic. All right, so now on to what can we do to improve HIV testing, and during the pandemic and beyond. So this is a study out of Ward 86 in San Francisco, that looked at viral suppression rates in their safety net clinic during the COVID pandemic. And what they found is that the odds of viral non-suppression were 31% higher post shelter in place. So starting in mid-March 2020, and this was despite stable retention and care and visit volume. Just like here at the Owen Clinic, they had this rapid implementation of telemedicine. But despite that, they still saw a 31% reduction in viral suppression, which was particularly prominent amongst homeless individuals in their clinic. But here at the Owen Clinic, and these are our telemedicine visits. So we also rapidly scaled up telemedicine in March and April of 2020 under the incredible leadership of Darcy Wooten. And in April, you can see that about 80% of our visits were actually telemedicine. But what's interesting, and just like Ward 86, we really maintained the same visit volumes. You can see even some months maybe had higher visit volumes than at least January and February 2020. And probably in part to telemedicine. And the thought is that we were reaching folks maybe that had barriers to coming in to the clinic for care, either because of transportation barriers or competing needs like childcare, work, etc. And unlike Ward 86, excuse me, we've maintained our viral suppression, which is really incredible, and maybe even has increased. And not entirely clear why this is, but I think in part to telemedicine, in part that, as I mentioned way in the beginning, that we had a COVID clinic here, so we've been had extra efforts to reach out to our patients to try to get them engaged and stay engaged in care. And one of the things I looked at with this is we in addition to not reducing visits, we also didn't reduce the number of viral load suppression measurements. So it's not like we're just measuring folks who could get here to the lab. So really incredible that we were able to maintain the same viral suppression in our patients throughout the pandemic. And that's really based on all the tremendous efforts of all of our providers and pharmacists here. Okay. All right, so now on to STIs and what can we do to better increase STI testing and HIV testing. So these are numbers from across the US that just show that basically all STIs have increased exponentially since 2015. And the numbers are no different here in San Diego, and you can see that we have higher chlamydia rates compared to the state of California, the western region of the US, and to the United States as a whole, and similar rates for gonorrhea and syphilis. So one thing that the Owen Clinic is doing to help combat these increased rates and also increase access for our patients to STI testing is we've recently implemented these home collection kits. So we have little biohazard bags that we give patients with their own swab and collection media with clear instructions on how to do this and bring them back to us. And we really hope that this will make collection far easier, follow up when patients need test of cure, and that we'll really be able to identify cases earlier and get people on treatment appropriately. And then this is really interesting, exciting news. So in October of this last year, the California State Legislature approved or became the first state in the United States to require that insurance companies cover the cost of at-home STD testing. And then Governor Newsom signed this bill into law, and this took effect the beginning of the year, so January 1st. It's very exciting because people will be able to do this testing at home for both HIV and multiple STIs. It's still unclear exactly how this is going to completely roll out. I think it's right now available to patients who have private insurance, but there's still limits based on deductibles that patients have. A lot of these tests aren't FDA approved. And I understand that for patients with Medi-Cal, there's still some contract negotiations going on, but it'll be very exciting. I'm really excited to work with Jill Blumenthal and our pharmacists and Christian Turner to see, how can we make these kits available to our patients? Can we dispense them from the Owen clinic? And how will these be reimbursed? But these something exciting for the future. All right, and then on to HIV testing. So some alarming data that only about 60% of US adults, 6% of US adults have never had an HIV test. And about 70% of people with higher HIV risks were not tested in the past year. And this is even pre-pandemic. And according to data from the National HIV Prevention Program and Evaluation System, the number of CDC-funded tests declined by more than 1 million in 2020 compared to the numbers in 2019, which represents a reduction of 46%. And here in San Diego, so the same year as the data above the national data, only about 46% of people living in San Diego had ever been tested for HIV, and only 14% during that year. So we need to do far better. And this is some interesting data. So the top is emergency departments at the University of Chicago Medicine that recognized very early in the pandemic that HIV testing rates were dropping off in their emergency department. So they really scaled up efforts to make sure that that important service wouldn't be impacted by the COVID pandemic. And they were actually able to scale up testing to more than 14,000 tests in 2020. And what they found was that acute HIV infections accounted for 12 of 46 new diagnoses in their emergency departments. And this was a significant increase compared to the previous 4 years. So by scaling up these efforts, they uncovered not only more new diagnoses, but also a number of acute infections. And they thought this is probably in people who were presenting with what they thought was COVID-19, because there's definitely symptom overlap between COVID-19 and acute HIV, and actually had acute HIV. So I think it would be amazing. We have this incredible infrastructure for COVID testing, and tents right across from where I sit here in my office. Like, how can we capitalize on this incredible infrastructure to help increase HIV testing throughout the US? And the study at the bottom utilized a previously calibrated dynamic HIV transmission model to look at the impact of COVID-19 and also what would be the cost effectiveness of linking opt-out HIV testing in 6 US cities. So they showed that implementing HIV testing alongside SARS-CoV-2 testing has the potential to reduce the number of HIV infections by up to 17% over 5 years, if 90% of people who present are offered the tests across these cities, and almost 60% accept. And while the strategy would require large upfront capital investment, they found that over time, this implementation would be cost saving across all of these cities. So in the last few minutes, I just wanted to highlight a few other important projects that are happening at Owen. I couldn't talk about them all today, but my other amazing colleagues here are doing this other really important work here. And then a few future directions at Owen. So in working with Amu Rajagopal and Lalo Kachai, we really want to scale up PrEP for people who use drugs and partner with our emergency department, our inpatient services, and community substance use disorder treatment programs and homeless shelters to refer folks to Owen who use drugs, both methamphetamine and opioids, to link them to PrEP and MAT and primary care. And then finally, I really love to partner with Susan Little and Tom Martin and Miley Karras to develop a patient-centered clinic here at Owen. And it could be modeled on Pop-Up, which is one at Ward 86, or the Max Clinic, or clinic could be any star that I was involved in Philadelphia. But the idea would be to co-locate medical and social services with flexible appointment scheduling to better address the complex medical and social needs of people not well engaged in care. And it would really be modeled. This is some of the data from Clinic of Any Star, the clinic that I know best. But we were able to found this clinic through a SPINGE initiative, and really focused on patients of Puerto Rican descent living with HIV who had a history of injection drug use. But we also didn't exclude anyone who needed our services. And you can see this population had a lot of comorbid social service and mental health needs. 40% reported being homeless in the previous month, 44% reported going hungry, 51% were suffering from depression, 15% incarcerated at any given time. And no one, just to be eligible to participate in this study, you had to previously not been engaged in care or been newly diagnosed. So very high risk population. And despite all that, by offering very flexible scheduling, people could walk in on a Wednesday without an appointment. They could schedule an appointment, but they didn't need to. And when they presented, they would be able to engage in case management services, harm reduction services, get a warm meal, get wound care. So everything they needed was there for them that day. And after a year of engagement with us, we had retained 85% of patients with an 83% viral suppression rate. And you can see how that compares to data in Philadelphia around the same time. All right. I'm just going to
I'm just going to remind you that it's 8:52. You're good.
Okay.
Oh, good.
All right. This is my summary. I'm just going to,
and go back to the slide before. You're good.
Well, so this is just to say, we have all these, this is, our toolkit with many more things. We already have injectables, which aren't on here, many more things. But if we don't get people access to these, if we don't think about how to improve insurance access and designing treatments that are specific to the patients who most need them, we're not going to get these important treatments where they need to go. And so this is my summary slide. So first of all, one of the simplest things we can do, I think, is just really emphasize U equals U, not only to people living with HIV at risk, because it's been shown to improve personal and public health. Sharing this information improves the social and emotional well-being of people with HIV, reduces stigma, reduces anxiety related to testing, and helps motivate treatment uptake, treatment adherence, and engagement in care. And the syndemic factors associated with decreased engagement in care and increased HIV acquisition, so depression and substance use, must be addressed and integrated into clinical care programs. And further research is needed into how we can optimally deliver this care in a culturally competent way. And really engaging patients. I think asking patients how they want the care delivered to them. And the demographics and gender diversity of people living with HIV in the US requires tailored approaches. We still see, this is a disproportionate HIV epidemic amongst Blacks and Hispanic persons. And that's really potentiated by structural racism and requires culturally appropriate engagement. And there's still crucial gaps in knowledge about the HIV epidemic, particularly regarding data on infections among trans feminine, trans masculine, gender non-binary communities. Also, I know Nettie Aldrich had pointed out a few weeks ago that we also don't know much about people coming across the border and border towns. That's another population that we don't, there's crucial gaps in knowledge about. Access to PrEP needs to be enhanced for primary prevention and made available to all at considerably lower cost or perhaps no cost at all. And we need to increase access to HIV screening through novel and innovative approaches. And finally, intensify our prevention efforts in the populations most affected by HIV. And really, without Medicare for all or a single payer system, It's, I think, really hard to achieve all of those. So that was for Will Toperoff, who we affectionately call Bernie Sanders' brother. All right, and then finally, this is a quilt or panels of a quilt that everyone at the Owen Clinic put together for our patients to commemorate 40 years of the HIV epidemic last summer. All right. And that is all. Thank you, Jill.